My name is Ellen, and I'm the patient representative in the group that has produced these guidelines. What that means is I bring my own lived experience of many years of suffering from an eating disorder and being in treatment, but I also try to bring in the perspective of patients I've met through the focus group Sign ran in the early stages of producing this guideline, as well as from my work as an ambassador for BEAT, the eating disorder charity, and of course the people I've come to know through my own time in treatment. It is these people, those with eating disorders, current, past, and future patients, that I want to speak directly to today because the entire process of producing these guidelines and this consultation are about improving the experience of care they receive. I've been given this slot to introduce these guidelines, so I want to use my time to discuss some of the key issues that came up in the early focus groups where SIGN representatives met with patients and what's in these guidelines to address these issues. The first one is barriers to accessing treatment. Specifically, people being told that because they are physically well, they do not meet the criteria for receiving help. These guidelines highlight the need for early intervention rather than waiting for people to become critically medically unwell. But we need bigger changes in the way our healthcare system and eating disorder services are designed in order for early intervention to be possible. This is a very real problem that these guidelines alone cannot solve. It makes no sense on any level to have to get worse in order to access help. My hope is that the recommendations for early intervention in the guideline will be implemented because the evidence is clear that this is effective. The second issue follows on from the first, and that's conflating weight with mental health. What we heard and what many people experience is that when people are in treatment for a restrictive eating disorder, the focus is on physical health. And then once they reach a certain weight, they're considered recovered and support is taken away at a time when it is most needed. What I hear time and time again, and have experienced myself, is that this is the hardest stage of recovery. All the coping mechanisms have been taken away, but mentally nothing seems to be any different. It is acknowledged, for the most part, that weight is only one measure of health, and yet it is too often conflated with recovery. What we found when reviewing the literature is that weight gets conflated with recovery all the time because it is very easy to measure. And so terms like recovery and relapse have started to lose meaning because recovery means weight restored and relapse means weight loss after treatment. There is too little emphasis on the psychological change which is needed for things to be different, for the quality of people's lives to have improved by the time they finish treatment. This has proven to be problematic for the writing of these guidelines, as there is no agreed upon definition of recovery. We need more research into this, but also more conversations with patients. I had been in treatment for over 10 years before a psychiatrist asked me what it was I wanted out of my treatment. Maybe recovery would not be so hard to define if patients were engaged more collaboratively with their care. The third and final issue I want to address is the language used to talk to patients. Time and time again, I hear stories of people being labelled treatment resistant or being told by clinicians that they will never get better, that their inability to change is because they don't want it enough. The implication, of course, being that wanting to change should somehow be enough to make that change happen. It just doesn't work like that. My own time in treatment was often a fraught process because the professionals involved in my care so openly expressed their frustration as I struggled to make progress. I felt blamed and isolated. As it transpired, I was not at all treatment resistant. I just needed different treatment. Blaming patients for ineffective treatment has to stop. What we know about eating disorders and the treatments we currently use is that not everybody will respond in the same way. There should be a time to pause and reflect on the treatment, not a time to dismiss the patient as untreatable. When I think about the patients I have met at focus groups during my time as an ambassador for BEAT or through my own time in hospital, I think of people who have struck me as determined, thoughtful, selfless, and caring. Yet they have all told me how medical professionals have labelled them as selfish, manipulative, controlling, somehow responsible for their own difficulties. These are people who almost always want to get better and yet feel paralysed at a point where the fear of change outweighs the fear of staying the same. For me, I began to get well when the balance tipped, and I was more afraid of staying the same than I was of making changes. What the evidence we have looked at shows is that it doesn't matter how long someone has been unwell or how many times they have been in and out of treatment. Change is possible, and there is hope of life beyond an eating disorder. The SIGN group had long discussions around terminology, and it has been a deliberate decision to avoid using phrases like treatment resistant or language that blames patients in this guideline. My hope is that this will bring about much needed change in practice and patient experience. I think I've used up my 10 minutes now, so I will end here. But I want to say again that the purpose of this guideline is to improve treatment for people with eating disorders. So please, any patients that are here today, please use this opportunity to ask questions, comment, raise any objections or concerns you have. Tell us what you think. Your feedback and your opinions really do make a difference. Thank you.